up one idea. Make that idea your life. Think of it, dream of it, live on that idea. Make your brain, your muscles, your nerves, each and every part of your body resonate with that idea. Leave every other idea alone. Yes, that is the only way to success. So if you have anything in your mind that you want to achieve, let your thoughts, let your words, and let your actions lead you towards your goal. Yes, each and every thought, each and every word should be uplifting. Each and every thought and word should lead you to your goal. Never think you cannot do it. Don't bring any negative, any demoralizing thought. Don't speak a negative word that you will not be able to do it. Let your body, let your mind, let your nerves, each and every muscle believe that you are going to do it, you will do it. That is the only way to success. So with that beautiful thought, let us start with another important topic of the year, and that is chronic otitis media. The name tells us that it is otitis media, which is chronic, which means that the middle ear, otitis media, middle ear is chronically getting exposed to infection from the outside. Now, we know that infection from the pharynx, any acute infection of the pharynx can come through the eustachian tube and become acute infection of middle ear. That is acute otitis media. Now, how can any infection chronically reach the middle ear? Which means, how can the middle ear be chronically exposed to infection from the outside? Yes, the middle ear is separated from the outside through the tympanic membrane. So, which means that if it reaches chronically to the middle ear from the outside, it is reaching through the tympanic membrane, which means that the prerequisite for chronic otitis media is a permanent abnormality of the tympanic membrane. Is that clear? So, if there is a permanent abnormality of the tympanic membrane, that permanent abnormality can chronically expose the middle ear to infections. So, that is what we need to remember here, that the prerequisite or the characteristic of chronic otitis media is a permanent abnormality of the tympanic membrane. Chronic otitis media can be either chronic mucosal otitis media or chronic squamosal otitis media. So in this module, we will be dealing with the chronic mucosal otitis media, which is also known as tubotympanic chronic otitis media, or earlier it was known as SAFE CSOM. Nowadays, it is most commonly known as mucosal otitis media. Why? Because here the mucosa of the middle ear is chronically getting exposed to infection from the outside. Yes, through a permanent abnormality of the tympanic membrane. And what is the permanent abnormality of the tympanic membrane here? Yes, it is a permanent central perforation of pars tensa. So each and every word of this is important. It is a permanent, it is central perforation of the pars tensa. Yes, so whatever perforation that you are seeing here, we know what is central perforation. Central perforation is any perforation on the pars tensa where it is not involving the annulus. Yes, so it can be anterior, it can be posterior, it can be inferior, it can be subtotal perforation. So any perforation of the pars tensa which is a central perforation but it is permanent. So what's the meaning of permanent perforation? So you are first going to tell me any condition of the middle ear which can lead to a perforation of the tympanic membrane. Any condition. Tell me any condition which can lead to, following which there can be a perforation of the tympanic membrane. Okay, trauma. Okay, very good. Any other infection you know of? Yes, acute otitis media. Acute otitis media can lead to perforation of the tympanic membrane. Does this perforation following either trauma or following acute otitis media heal? Yes or no? Yes, it heals. Does it heal by itself? Yes, it heals by itself. Usually in how much time? In 3 months' time. By chance it is not healed. If it is not healed, why has it not healed? Yes. So what happens in the perforation is, so if this is the perforation of the tympanic membrane, how does it heal? The tympanic membrane we know has 3 layers. Outside is the epithelial layer, in between is the fibrous layer, and inside is the mucosal or the endothelial layer. So the epithelial layer grows, meets the other side and the outside layer is closed. Endothelial layer grows and meets the other side and the inside layer is closed. Yes, so we know that this perforation, if it heals, it will heal by 2 layers, and this will usually heal in 3 months' time. Now, if this perforation, if the epithelial layer, instead of growing like this, if the epithelial layer grows like this and it meets the endothelial layer, so now what has happened? The moment it meets the endothelial layer, there is contact inhibition, and now this perforation will not heal. The margins have become epithelialized. So this is what we call as a permanent perforation. So which means that now this perforation has become permanent, and this permanent perforation will chronically expose the middle mucosa to infection, and this is what we call as chronic mucosal otitis media. Which means if the patient anytime comes and tells you that I have perforation, he's telling you that I am having perforation of my eardrum for around 1 month or 2 months, then you will label it as acute otitis media. But if it is anything more than 3 months, it means the margins have become permanent. There is a permanent perforation. Now you will label it as chronic otitis media, chronic mucosal otitis media. So if it is 3 months, if it is 6 months, if it is anything more than 3 months, 4 months, if it is 6 months, if it is 1 year, if it is 10 years, then it is chronic mucosal otitis media. Is that clear? That will become chronic. So here is this patient whose tympanic membrane has been given here, and yes, we are seeing a big subtotal perforation here of the pars tensa. So what will be the complaint that the patient will have whenever he has a chronic otitis media, whenever he has a permanent perforation of the pars tensa? What will be the complaint of the patient? Yes, very good. The patient will have discharge. Yes, can you tell me the characteristic of the discharge? Yes, it will be mucoid or it will be mucopurulent. Mucoid or mucopurulent. Yes, always remember, if there is discharge in the external auditory canal and this has a mucoid component, it indicates that it is coming from the middle ear. Why? Because in the external auditory canal, we have stratified squamous epithelium. We nowhere have mucus glands. Mucus glands are present where? Only in the middle ear. So if there is mucoid component in the discharge which is lying in the external auditory canal, we know it has come from where? From the middle ear. So this will be a discharge which will be mucoid or mucopurulent, and it will be profuse. It will be profuse. It will be because of involvement of the whole of the mucosa of the middle ear. So a lot of discharge will come out from the external ear. So the patient will have mucoid, profuse and painless. It is a chronic low-grade infection. It will not lead to acute severe pain here. So there will be no pain. It is painless. And when will this patient have discharge? Will this ear with the perforation of the tympanic membrane always be discharging? No, the patient will tell you that whenever there is any water that has gone inside. So these patients, when they know that there's a perforation of the tympanic membrane, they know if the water goes inside, it will discharge. So you specifically ask them to close the ears while taking bath. They have to put a cotton in the ear, and they can put a Vaseline over the cotton so that even if the water goes over it, it slips over it, it does not go inside. Yes, so they know that if water goes inside, the ear will discharge. Also, they know that whenever they have any infection of the throat, then the ear discharges. So that is when they come to you. They will tell you that whenever I have throat pain, yes, that time what happens? Through the eustachian tube, the infection goes into the middle ear, and then the ear starts discharging. That is why this was also very commonly earlier known as tubotympanic chronic otitis media, because whenever through the eustachian tube, the infection goes to the tympanic cavity, that is when the patient comes to you. That is tubotympanic CSOM. Nowadays, also it is known as that, but more commonly it is known as chronic mucosal otitis media. So patient will come to you whenever there is discharge. Discharge will occur only when there is infection, because of infection going from the outside through the external auditory canal through water, or from inside through the eustachian tube by following pharyngitis or sinusitis. And the other complaint, what will be any other complaint? Will it be there? Yes, there will be deafness. There will be hearing loss. There will be deafness. Yes, how much will be the deafness? Why deafness? Deafness because tympanic membrane perforation. So tympanic membrane perforation can lead to how much hearing loss? Tell me quickly, how much? Yes, about 10 to 40 decibel hearing loss. Also, can there be ossicular necrosis in this condition? If there is repeated infection of the middle ear, then that can lead to ischemia, and that can lead to necrosis of the ossicular chain, and that will lead to ossicular discontinuity. So here it is asked that which is the most common ossicle to get necrosed following any infection of the ear. If ossicle gets necrosed, usually in acute infection, why should the ossicle get necrosed? In chronic infection, when the ossicles get necrosed, what is the most common ossicle to get necrosed? The most common is the long pros of incus. The incus articulates with the stapes here like this. Yes. So this area has got a very precarious blood supply, very poor blood supply. So the most common ossicle to get necrosed, most common ossicle is the incus lenticular process. Lenticular process by chance is not there in the choice, then the next becomes long process. Long process. Followed by, next most common is, what is this area? What will this involve next? Yes, the stapes. The stapes suprastructure. So if there is ossicular necrosis also, then the hearing loss will be more. It will be more than 40 decibel. More than 40 decibel. So these are the two main complaints that the patient will come to you with. Patient will come with hearing loss and patient will come with ear discharge, which occurs on and off whenever the ear gets infected. So if the ear is discharging when the patient has come to you, that is what is known as active disease or active mucosal otitis media. And if when the patient has come to you and the ear is dry, then this is known as inactive mucosal otitis media. So here is a patient who has come to you with a complaint that his ear starts discharging on and off, and also yes, there is hearing loss. And when you examine the ear, what you see is a picture like this. You are seeing a perforation of the tympanic membrane. Yes. So just by seeing the perforation of the tympanic membrane, can you make out whether it is permanent or not? Do you take a biopsy to confirm it is permanent or not? Do you take a biopsy from the margins to confirm whether it is epithelialized or not? No? Then how will you know that this is chronic otitis media? Yes, history. That is where the history will tell you whether it is acute or chronic. So the patient, if the patient has been having this discharge on and off for more than 3 months time, 6 months, 10 months, 1 year, then you know it is chronic otitis media. So you have confirmed that this is a patient of chronic otitis media. What should you do now? Will you give medical management to this patient? Will the perforation heal by medical management? Yes or no? Is this a permanent perforation? Yes, if this perforation had to heal, it would have healed within 3 months. It has not healed in 3 months' time, means the margins have got epithelialized, and now it will not heal by any medical management. It will not heal by itself. So the management will then be repair of the tympanic membrane. And what is tympanic membrane? Known as miring. And plastic repair of the tympanic membrane is what is known as myringoplasty. But if the patient's ear is discharging, it is active mucosal right now. It is active. So in this patient, can you do any surgery? Do we do any surgery when there is acute infection? Never. So what we will do if the ear is discharging? Then in this case, we will give medical management. Is that clear? So the management when the ear is active will be antibiotics. Antibiotics both local as well as systemic. And always when you give local antibiotics, ear drops, you also have to advise the patient to clean the ear. Whenever he puts the drops, before that he has to clean the ear with cotton. What is that? Yes, oral toilet. So before local ear drops, he has to always do oral toilet. He has to clean the ear so that the discharge is cleared and the ear drops will be able to reach up till the middle ear mucosa. So you have to go for both local and systemic antibiotics. Antibiotics against which organism? So what is the causative organism here? Yes, chronic is always a mixed infection. It is a mixed aerobic and anaerobic infection. Mixed aerobic and anaerobic infection. So you give antibiotics, you give oral toilet, you give local and systemic antibiotic, and once the ear is dry. Now once the ear is dry, then you can post the patient for myringoplasty. I have given antibiotic to the patient and the patient's hair has become dry. Should I post him for myringoplasty next week? Yes or no? No. The ear has to become dry and it has to remain dry for at least 6 weeks without antibiotic, which means that I will give antibiotic, and after that, when the antibiotic stops, after 5 days, when the ear is dry and the antibiotic I have stopped, after that I will wait for 6 weeks. I will wait for 6 weeks for what? Yes, to see that there is no chronic focus of infection. If there is any chronic focus of infection, if I stop the antibiotic, then the ear will again discharge. So if the ear again discharges, I know that there is some chronic focus of infection and the ear has to be absolutely dry before, it has to be absolutely free of infection before we take up the patient for surgery. So I will wait for 6 weeks without antibiotic. If the ear remains dry, it is that time when I will post him for surgery. So the surgical repair of the tympanic membrane is what is known as myringoplasty. It is known as myringoplasty. Myring is tympanic membrane and plastic repair of it is myringoplasty. And if it is already inactive, then in that case, we can post the patient for myringoplasty. Now, if the patient's ossicular chain is also necrosed, as you are seeing in this picture, just see very carefully. Can you see here this ossicle? What is this ossicle? Yes, this is a long process of incus. Can you see it is not looking normal? Yes, see carefully, it is appearing a little necrosed. So if the long process of incus is also necrosed, like in this patient, yes, then just will a myringoplasty suffice? Yes or no? No, it will not. What will you have to go for? You will also have to go for repair of the ossicular chain. So you will have to go for ossiculoplasty along with myringoplasty. And what is that known as? Myringoplasty. Myringoplasty plus ossiculoplasty is what is known as tympanoplasty. This is known as tympanoplasty. In fact, is it very important to know before operating the patient that the ossicular chain is normal or not? Yes, it is. Why? Suppose this is a patient where we have posted him for myringoplasty and by chance we missed that his ossicle is necrosed and we just close the tympanic membrane. What will happen following surgery? Initially, this patient had a hearing loss of around 40 decibel. This patient had a hearing loss of around 40 decibel and by chance this did not make us remind that 40 decibel can be because of just a perforation or 40 decibel can also be because of a perforation with ossicular discontinuity. We were happy that okay, just a perforation can lead to 40 decibel hearing loss, yes, and we posted the patient for surgery and we operated and closed the tympanic membrane. So you missed the ossicular chain discontinuity and what you did is you closed the tympanic membrane. So now what will happen after surgery? Yes, after surgery now the hearing loss will increase from 40 to 55 decibel. 40 to 55 decibel patient came to you with hearing loss. Yes, you operated him and after that you gave him more hearing loss. Yes, why it will increase to 55 decibel? Yes, initially what was there is that the patient had ossicular discontinuity. So through the ossicular chain the sound was not going to the oval window, but at least there was a perforation through which sound could directly go to the oval window and stimulate it. But now what you have done, you have closed that pathway also. You have closed that also. Sound cannot directly go also now. So the hearing loss will increase. So which means that before surgery, we need to know whether the ossicular chain status is, what the ossicular chain status is, whether it is normal or not. How can you know that? Yes, you can either know by examination under microscope. So the ossicular status can be known by either examination under microscope. Examination under microscope is known as EUM. EUM. Examination under microscope or through endoscope. If the perforation is very big, then we have autoendoscopes. Autoendoscopes. You can have a look, or a very simple method, OPD method, is by doing a patch test. patch test. What is a patch test? In this patch test, you just take a paper patch and you close the tympanic membrane perforation. You place it over the tympanic membrane perforation. Now, if it is only perforation that the patient is having, the ossicular chain is normal. What will happen if you close the perforation? Hearing will improve. But if there is ossicular discontinuity and you have closed this perforation, what will happen? The hearing will worsen. So by just putting a patch of paper over the perforation, you can get an idea about the ossicular status. And now whether it is just a tympanic membrane perforation or it is ossicular discontinuity also, accordingly you can go for myringoplasty or you can go for tympanoplasty. So when we are doing this surgery, either myringoplasty or tympanoplasty, our aim of surgery is first to give the patient a dry ear, give the patient a hearing ear, and another very important reason why people want to get the surgery done, closure of the tympanic membrane perforation, is so that they can participate in water sports. So they can take part in water sports. We know that these patients who have perforation of the tympanic membrane, even if little water goes inside, there is chances of discharge. So this is a very important indication, aim for surgery, to participate in water sports. So how do we approach the tympanic membrane? We are seeing that there's a perforation on the tympanic membrane which we want to close. So how should we approach this tympanic membrane to repair it? Yes, either we can give a post-oral incision, we can retract the pinna forward, and then through the external aortic canal, bony part, we can go and operate on the tympanic membrane. Yes, when I saw this happening for the first time, I got so scared that the pinna is being cut and God knows what this patient is going to do after that. Yes, so why is the pinna put forward? So that it does not interfere in the access to operate on the tympanic membrane. These are very minute, very microscopic, very specialized surgeries which you have to do with a lot of expertise and lot of caution. And because it is microscopic and the area that is available is so little, it is just a small thin external aortic canal. And if the pinna is also there, so that becomes a hindrance in the access to the tympanic membrane. So that is why you can go for a post-oral approach. And a post-oral approach, this incision is what is known as Wild's incision. This is known as Wild's incision. Or also what you can go for, if the tympanic membrane perforation is not too large and if the external aortic canal is a little wide, what you can go for is you can give an incision to widen the external acoustic meatus, and you can directly go through the external aortic canal here itself instead of giving a big post-oral incision. So when you give the incision here, that is what is known as, you are giving incision in the incisura terminalis, intercartilaginous incision. That is what is known as a Lempert incision. Lempert incision. So how is the Lempert incision? This is Lempert end oral incision. Yes, it is given here like this. Lempert end oral incision. Or also what you can do is, if the external aortic canal is quite wide and the perforation is very small, instead of giving an incision either here or here, you can just give an incision just lateral to the tympanic membrane on the external aortic canal, and you can raise the external aortic canal skin flap from here itself. This is what is known as Rosen's incision, Rosen's transcanal incision. Now, why we give an incision to raise the external aortic canal epithelium, I will just show you, you will understand it then. So after we have given the incision to repair the tympanic membrane perforation, the graft that we use most commonly is a temporalis fascia graft. Most common is a temporalis fascia. Yes, we have the temporalis muscle over the in the temporal fossa here. So the temporalis fascia overlies, as you can see here, this white fascia of that overlies the temporalis muscle is what is known as a temporalis fascia. This is most commonly used as the graft, or a tragal perichondrium. Tragal perichondrium, perichondrium over the tragal cartilage. Can be used as a graft. Sometimes cartilage graft is also used, or fat graft is also used. Most commonly what is used is the temporalis fascia graft. So this graft is then placed over the perforation, and there are two types of myringoplasties that can be done. It can be either underlay or overlay. So let me first show you what is underlay and overlay, and then we will write it down. So here we have the tympanic membrane in which we are seeing a perforation in the center. What we are seeing, this is the tip of the handle of malleus. Yes. So what we first do is, we know that the margins have got epithelized, because of which this perforation is not healing. So we freshen the margins, means that we remove a thin rim from all around the perforation. So when we remove the thin rim, along with that all the epithelized margins comes out, and this margins become fresh again, ready to heal again. So now this is the tympanic membrane. These are the three layers of the tympanic membrane. This is the outer epithelial layer. This is in continuity with the external auditory canal epithelium. Yes, this is what is the fibrous or the middle layer, and the innermost layer is the mucosal layer, which is the same as the lining epithelium of the lining endothelium of the middle ear. So now what we are doing is, we have given the incision, either the post-oral incision or the Lempert incision, or we have given an incision that is just in the external auditory canal lateral to the tympanic membrane, a few millimeters lateral to tympanic membrane. That is what is known as the Rosen's incision. Now we raise the epithelium of the external auditory canal. We know the same epithelium comes to line the outer surface of the tympanic membrane. So what we will do is, we will raise this epithelium. So now when we have come up till the margin of the tympanic annulus, so now what we do is, that is the tympanic sulcus, what we do is, we raise the, along with the epithelium of the external auditory canal, we raise the epithelial layer of the tympanic membrane, right? So we have raised it, and now we are going to place the graft that we have taken. This, we have taken a temporalis fascia graft. Okay, now this graft we are placing over the fibrous layer like this. See, I have placed the graft. Yes, I have placed the graft over the fibrous layer, and now I deposit the epithelial layer. Can you see that the perforation is healed now? Yes. So this is what is known as overlay technique. Overlay technique. Yes. Now when I am doing overlay technique, when I am placing over, means I am placing it over the fibrous layer, I can place this temporalis fascia graft either over the malleus, handle of malleus, or I can place it like this also. I can place it under the handle of malleus also. If I place it under the handle of malleus, then it gets some support from the handle of malleus. It will not get extruded easily. Okay, so overlay does not mean that you are placing it under the handle of malleus or over the handle of malleus. It has got nothing to do with the handle of malleus. It has got to do with whether you are placing it over the fibrous layer or under the fibrous layer. So this is what is over the fibrous layer, so it is overlay. Now suppose I am doing underlay. So how will I do underlay? In underlay, what I am doing is, instead of just raising the epithelial layer of the tympanic membrane, when I am raising the epithelial layer of the external auditory canal by whatever incision I have given, either a post-oral incision, I have started raising the external auditory canal epithelium either quite laterally or just next to the tympanic membrane by Rosen's incision. Now I raise, and when I reach the tympanic sulcus, instead of just raising the epithelial layer, I raise the whole of the tympanic membrane. And now I am placing the graft under the tympanic membrane. Can you see I have placed the graft under the tympanic membrane? Yes. Now, can you see that it is healed? Now again, when I place it under the tympanic membrane, I can place it either under the malleus or I can place it over the malleus. Is that clear? It has got nothing to do with where in relation to the malleus you have placed the graft. It has got to do with whether you are placing it under the tympanic membrane or you are placing it over the fibrous layer, which gives us the name underlay or overlay. Have you got that? So the myringoplasty can be either underlay or it can be overlay. So myringoplasty can be either underlay or overlay. It can be underlay or it can be overlay. Underlay is under the whole tympanic membrane. The whole of tympanic membrane, whereas overlay is over the fibrous layer. So now quickly keep your pens down. Sit straight. Yes, okay. Now quickly tell me what is the most common, what is the characteristic of chronic otitis media mucosal? Yes, a permanent perforation of the pars tensa, permanent central perforation of the pars tensa. Yes, very good. Okay, what is the complaint of a patient of chronic otitis media mucosal variety? Yes, discharge and deafness. So here is a patient who has come to us with a complaint of discharge, ear discharge, and he is having hearing loss. If this discharge is coming from the middle ear, what will be the specific feature of the discharge? What will be the character of the discharge? Yes, very good. It will have a mucoid component. Will any discharge of the external aortic canal of furuncle or of any infection of the external aortic canal, diffuse otitis externa, will it have a mucoid component? No, it will not have a mucoid component. Okay, so if this is chronic otitis media, what will be the appearance of his tympanic membrane? He is telling me that he has discharge from the ear, and that has been happening on and off repeatedly for the past many years. Yes, and he has, yes, hearing loss. So what is in our mind is that this can be a patient of chronic mucosal otitis media. If this is chronic mucosal otitis media, if I have a look at his tympanic membrane, what will be the appearance of tympanic membrane? Yes, there will be a perforation anywhere on the pars tensa. And how do I know it's a permanent perforation? Yes, he is giving the history of many years. It is many years. So anything more than 3 months is permanent perforation. So now I have confirmed that this is a patient of chronic otitis media mucosal variety. How will I manage this patient? How will I manage this patient? Yes, should I post him for surgery for laryngoplasty? Yes or no? If his ear is discharging, then no. If the ear is discharging, then the management will be first medical management. Medical management till the ear is dry, and then should I immediately post him for surgery? No, wait for at least for 6 weeks till the ear is dry without antibiotics for at least 6 weeks. Only then we can post him for surgery. What surgery will you go for? Will you go for a myringotomy here? Yes or no? Myringotomy. Making a omi on the myring, on the tympanic membrane. Already there is a perforation. Why you want to give one free? No. So what will you do is repair. Repair of myring is known as myringoplasty. If ossicle is also necrosed, then tympanoplasty. Then if the ossicle is necrosed, what will happen when you patch the perforation of the tympanic membrane? Will the hearing loss increase or decrease? It will increase. If there is only perforation, no ossicular discontinuity, then the hearing loss will improve. Then it will improve. Okay, so then we are going to go for myringoplasty or tympanoplasty. Yes, will you place the tympanic membrane graft over the malleus or under the malleus for underlay and overlay? Over the malleus or under the malleus? Nothing to do with malleus. It is over, overlay is over fibrous layer. Underlay is under the whole of the tympanic membrane. So now we know how we are going to manage, and suppose if there is ossicular discontinuity, then we will have to go for tympanoplasty. So we need to know which ossicle, when necrosed, which tympanoplasty we are going to go for. So tympanoplasty has been divided by Woolstein into 5 types. So type 1 tympanoplasty is when you place the graft in contact with the malleus. Either you can place it over the malleus or under the malleus. When you're placing it in contact with the malleus, that is type 1. Type 1 is the same as myringoplasty. Type 2 is, so you can remember, 1 is in contact with the first ossicle, 2 is in contact with the second ossicle. So what is the second ossicle? Second ossicle is the incus. So when you are placing the graft, what graft we are talking about? Yes, the temporalis fascia or the tragal perichondrium, whatever graft we have taken. So when we are putting the graft over the second ossicle, that is the incus. That is what is known as type 2. And when you are placing the graft over the third ossicle, that is the stapes. That is what is type 3. This is what is known as type 3 when you're placing it over the stapes. Now, one of the tympanoplasty of 1, 2 or 3 is what is known as columellar tympanoplasty. So, which one is the columellar tympanoplasty? Columella gets its name from ossicles in the middle ear of birds. In the middle ear of birds, there is only one ossicle. Yes, so the tympanoplasty in which in the middle ear there is only one ossicle, that is columellar tympanoplasty. Which one is that? Type 3. So till here it is very easy. Or 1 is when you place it over the first ossicle, the graft. 2 2 is when you place the graft over second ossicle, 3 is when you place the graft over third ossicle. Tell me what will be 4. Yes, so type 3 is when you plate the myring over the stapes. It is known as myringostapediopexy, or columella tympanoplasty. Tell me what is 4. 4. 1, 2, 3, I have told you 4. 4 over the foot plate. Will that be 4? Whether you place the graft over the head of the stapes. Okay, now just see here. If you are placing it, the temporalis fascia graft directly over the head of the stapes, that is 3. Okay. Or if you're placing it over the foot plate, that is also 3. Anywhere over the stapes head or over the foot plate, all that is 3. Anywhere over the stapes is type 3 tympanoplasty, columella tympanoplasty, myringostapediopexy. Now, when we place it over the stapes head, can you see here that the middle cavity has become very narrow? Yes. So that is why we usually do not prefer placing it directly over the stapes head. What we do is, we first place a prosthesis over the stapes head, and then we place the tympanic membrane, the temporalis fascia graft. So this process that we use is what is known as PORP, or it is known as partial ossicular replacement prosthesis. And when you place the prosthesis directly over the foot plate, this is what is known as TORP. This is what is known as total ossicular replacement prosthesis. So whether you use PORP, whether you use TORP, or whether you place the temporalis fascia graft directly over the stapes, if you are placing it anywhere over the stapes, that is type 3. That is not type 4. Then what is type 4? Yes. What we do in type 4 is we maintain the phase difference. What is phase difference? Is that whenever the sound reaches both the windows at the same time, the oval and the round windows at the same time, it will cancel each other. Yes, so if there is nothing that we can do, what we can at least do is we can leave one window open and one window we can close, so that the sound reaches only one window and at least the phase difference is maintained. So what we do in type 4 is that we place the graft over the round window. So which means that if this was the middle ear cavity, this was the medial wall here, you are seeing the oval window here, you are seeing the round window here. So what you do is you place the graft, instead of placing the temporalis fascia graft here covering the whole of the middle ear cavity, now what you have done is you have placed the graft like this. You have placed the temporalis fascia graft like this, only covering the round window. So this middle ear cavity, which was this big here cavity, what you have done is you have made it into a small cavity which has now the round window inside, and this oval window you have exposed to the external auditory canal, so that sound can now directly go to the oval window and it can stimulate it and the phase difference is maintained. This is what is type 4. So in type 4 what you are doing is you are maintaining the phase difference. In fact, it has been asked in your exam that which perforation of the tympanic membrane leads to maximum conductive hearing loss. So which perforation? A perforation which will expose oval and round window at the same time. Which perforation? Posterior-superior perforation. So a posterior-superior perforation leads to maximum hearing loss. Maximum hearing loss in a perforation. If we are talking about all the perforations, then which perforation lead to maximum hearing loss? Yes, posterior-superior perforation. And also because of that, sometimes when patient has patients of ear discharge, patients of chronic otitis media, they will tell you that when I have ear discharge, my hearing improves. When my ear is dry, my hearing is not very good. But when my ear starts discharging, they are known as discharge hearers. Yes, when the ear is discharging, then I can hear good. Why so? Yes, because when the ear is discharging, the pus, that is because of gravity, it is in the lower part of the middle ear cavity, it is collected. So that tends to cover the round window. So that maintains the phase difference at that time. So that is what is known as round window baffle effect. Round window baffle effect. Round window baffle effect. What is that? that the round window gets covered. Round window is covered by discharge. By discharge, or it is protected. And phase difference gets maintained. Because earlier when the perforation was dry, when the air was dry, sound was reaching both the oval and the round windows at the same time. And now because the discharge has covered the round window, the sound is reaching only the oval window. The round window is protected. The round window is covered. So the phase difference is maintained. So that is the round window baffle, also known as round window shielding effect. Round window shielding effect. So what is type 5? Type 5 is when the footplate was fixed. Initially, surgeons used to think that footplate is fixed. Now, how will the sound go inside the inner ear? On the medial wall, we know we have the oval window on which is present the footplate. So, footplate was fixed. So, now surgeons thought that how will the sound go inside? They saw a bulge here. What is this? The bulge of? Is this the bulge of lateral semicircular canal? So, what they did was they made an opening here. So, okay, this is fixed. Sound will go through this. This is what is known as the fenestration operation. And this was led to creating of a fistula on the medial wall, because of which any pressure changes or loud sound would stimulate the inner ear, leading to vertigo. This is no more done. Type 5 tympanoplasty is fenestration operation. It is no more done. It led to the fistula test becoming positive. So it is no more done. So nowadays you can do either 1, 2, 3 or 4 tympanoplasty. So quickly you're going to tell me what is the management of mucosal otitis media. Mucosal otitis media. Yes. Or safe CSOM. What is the management of tuber-tympanic chronic otitis media? Yes. The moment you hear safe CSOM, the moment you hear mucosal otitis media, a picture of a perforation of the tympanic membrane should come to your mind. What is the management? Yes. Close the perforation. Close the perforation. That is the best management. But if the perforation, if the ear is active, then you have to give the antibiotics. You have to give local and systemic antibiotic to make the ear dry. That is not the permanent treatment. That is not the definitive management. Definitive management is repair of tympanic membrane. What is repair of tympanic membrane known as? Meningoplasty or tympanoplasty. What is type 1 tympanoplasty? Quickly tell me how many tympanoplasties? Yes, 5 tympanoplasty. What is 1? Where you place a graft in contact with which ossicle? Malleus. 2 is in contact with incus. If you are placing it in contact with incus, it means what is missing? What is missing? Yes, the malleus is missing. That is why you're putting it on incus. Type 3. 3 is you're putting it on stapes. Yes, which means what is missing? Malleus incus is missing, or incus is missing. You can put it on stapes. What is type 4? 4? 4 is when you're putting it over the foot plate. Is that 4? No. 4 is when you're shielding the round window. And what is fenestration operation? Which tympanoplasty is that? That is type 5 tympanoplasty. And we have seen how the TORP and PORP look like. Yes, this was one of the image-based question that was given in your exam. How will you identify which one is PORP and which one is TORP? Both these are ossicular prostheses. Yes, the PORP is partial. It has to be put only when the stapes is present. It has to be put over the stapes head only when the stapes is present, which means that it will have a socket-like end to put over the ball-like end over of the stapes head. Whereas this TORP total has to be put when there is no ossicle. This has to be put over the oval window. This has to be put over the oval window. So the end is like this. The end is like this. Is that clear? So this has to be put over the stapes head. So this is PORP and this is TORP. Now just have a look here. Now here, just see that there are different types of ossicular loss in all these conditions. In the first one here, what we are seeing is that the incus is absent. So here what we will do is we will put either the graft over the stapes, or we can put a partial ossicular replacement prosthesis like this over the stapes head. So what tympanoplasty is this? Whenever we are putting the graft over the stapes, be it the temporalis fascia graft or the ossicular prosthesis over the stapes, that is type 3. So we are going for type 3 here. Okay. So here have a look at the second here. Now here the complete stapes is absent. So you will have to go for a TORP, total ossicular replacement prosthesis. So it will be like this. Something like this. So that is again type 3. This is again type 3. You're putting it over the foot plate. So that is again type 3. Whether you put it over the head or foot plate, anywhere over the stapes, that is type 3. So here also 3. Here also 3. Now see in this condition. Here what is there is malleus and incus both are missing. Now here again you will put the graft, that is a PORP, on the stapes. Yes. So this is again type 3 tympanoplasty. Type 3 tympanoplasty. Now here none of the ossicles are present. So what you will do is you will put a TORP, total replacement prosthesis, over the footplate of stapes. And so again this is type 3. Is that clear? So type 3, what is type 3? Type 3 is whether you put the graft directly over the stapes head or you put a partial ossicular replacement or a total ossicular replacement. All this is type 3. Which means that if following surgery you have just written that I have done a type 3 tympanoplasty for this patient, that does not give any idea to any other surgeon or to you also later on when the patient comes to you for follow-up. You are seeing so many patients, it is obvious that you will not remember what was the finding in this patient. So if you have just written that you have done a type 3 tympanoplasty, you do not know what was the status of the ossicular chain for which you did a type 3 tympanoplasty, whether only the stapes was present or none of the ossicles were present. Yes, so that is why the all these different types of ossicular chain abnormalities or ossicular chain defects were further classified by Austin. So that if I write that if only the incus is absent or if only the incus and stapes is absent, I can label it separately and I exactly know which ossicles were absent for which I did a type 3 tympanoplasty. So Austin classified them into 4 types, A, B, C and D. And his classification was based on, just see here, his classification was based on that since the most common ossicle to be necrosed is incus. As you can see, incus is absent here also. Here also it is absent. Here also it is absent. Yes, here also it is absent. So since the most common ossicle to get necrosis is incus, his classification was based taking into consideration that incus, if there is ossicular necrosis, if the ossicular chain is necrosed, if one of the ossicle is missing, definitely incus will be missing. Along with that, some additional ossicle can be missing. So in other words, when it is asked in your exam, what is asked is not that it is based on the absence of which ossicle. Austin classification is based on the presence of what? It is based on the presence of either the handle of malleus or the stapes head. Incus is missing in all, that is for granted. Now what we are seeing is whether both the handle of malleus and the head of stapes or either of them, which one is present, which one is absent. Is that very clear? So in class A, only the incus is absent. Just see here, it is malleus is present and stapes is present. So this is known as M plus S plus. Only incus is absent. Okay, next most common, if I ask you what will be B, what will be the type class B? Yes, so class B, what will be the next most common ossicle to be missing after incus? Next is, I told you that the most common site of least blood supply is that joint, the incudostapedial joint area, the incus and the stapes joint area. So most common is incus. Next most common will be stapes head will be missing. So that is B, absence of incus. So this is not based on absence of incus, this is based on presence of malleus or stapes. So here only malleus is present, stapes is absent. Yes, it is understood, incus is absent in all. Next is just the opposite of B, that is that the malleus is absent and the stapes is present. This is a very rare deformity, but still, if we have written that if this is present, then we can write in our notes that this was a Austin class C deformity. So that makes us understand that here the stapes was present, the malleus was absent. And the D is where everything is absent, malleus is also absent and stapes is also absent. So these are the 4 types of Austin classification. So now after that, Kartush added 3 more. Oh, Kartush, he added 3 more and this was now known as Austin-Kartush classification. Kartush said that if the ossicular chain is normal, that also should be mentioned, that also should be labeled. So if the ossicular chain is normal, it is named as type O. O means normal ossicular chain. ossicular chain. And F is when the foot plate is fixed. When the foot plate is fixed, that is autostenosis, that we have to label as F type of defect, or E. What is E? E is when there is head of ossicles fixation. When there is fixation of head of ossicles. Head of ossicles is fixed. That is again a very rare thing. Most common fixation, if it occurs, is foot plate of stapes. So if the head of ossicles is fixed, still that is a possibility. So then we have to write that it is E. So which means if in our notes or if in anybody's surgical notes it is given that the repair was done for E type defect. So it is understood that head of the ossicle was fixed, for which some repair was done. Some ossiculoplasty was done. So whenever we are doing a laryngoplasty, when we raise the tympanic membrane and we find that there is any ossicular defect, or if the ossicular chain is normal, accordingly we will repair the middle ear ossicles and the tympanic membrane. We will go either for laryngoplasty or tympanoplasty. Now, if it is just given, was a question given, what is the management of safe CSOM? What is the management of mucosal otitis media? Only this much was given. Ossicular chain, nothing was mentioned. And in the choice, both laryngoplasty and tympanoplasty was given. What will you mark? Will you go for laryngoplasty or will you go for tympanoplasty? Yes? Very good, tympanoplasty. Why not laryngoplasty? Because type 1 tympanoplasty is the same as laryngoplasty, yes or no? So if you say tympanoplasty, that includes laryngoplasty. Type 1 tympanoplasty is same as laryngoplasty. And you do not know the ossicular status. It has not been mentioned here. So how can you be so sure that the ossicular status is normal that you can write that I will go for a laryngoplasty only? Laryngoplasty you can write as the answer only if the ossicular chain is mentioned or if tympanoplasty is not there in the choice. If tympanoplasty is there in the choice, the better answer is always to mark tympanoplasty as the answer. So is that very clear? Now here, this is the patient who has come to me with a complaint of discharge from his left ear, and he's telling that he's been having discharge for the past 5 days, and for the past 5 days he also has some cold and some cough. So if he is complaining of discharge, it can be either external ear or it can be middle ear. So let me have a look what it is. So when I have the patient sitting in front of me, I have to examine, yes, so that most of the things will become clear once I examine. So yes, I have pulled the pinna posteriorly, and what I can see is, that there is discharge in his external auditory canal, and along with that I can also see a medium size anterior perforation. I hope you know what is medium and what is anterior. Yes, so he has a medium size anterior perforation. So now what comes to your mind? Yes, can it be acute otitis media, since the past 5 days he is giving the history, or is it a chronic otitis media? So now let me ask him whether he has been having this episode earlier also, because by seeing the perforation I cannot make out it is permanent or not, or it is sudden. Now he has given me the history of only 5 days. So do you have this? Did you ever have this discharge earlier also?
When I was 10, then whenever I have cold and cough.
Okay, so he's telling me that since he was 10 years old, he has been having this discharge, and whenever he has cold and cough, he has this ear discharge. So can you tell me it is a acute otitis media or a chronic otitis media? Yes, it is a chronic otitis media. His ear is discharging right now. What should I do? How should I go about managing this patient? What? Repair it immediately? First, I will give him medication, yes, for making his ear dry. So will that medication repair his tympanic membrane? Will that tympanic membrane which has the perforation, will it heal by the medication that I am going to give him? Yes, I will give him one antibiotic. I will give him ear drops. And in around 3 to 4 days, 5 days maximum, his ear will become dry. Will his perforation also heal by the medication? No, it won't. So right now I am giving you some medicines. You have to take this, but your ear will become dry, like how always it becomes dry whenever you take medicine. But you have a big hole on your eardrum that is not going to heal with this medicine. For that, we will have to repair your eardrum. We will have to put a new eardrum. But for that, your ear should be totally dry. The ear should not discharge. For at least how much? For at least 6 weeks after I stop the antibiotic. So then I will call him again, have a look at his ear. If it is absolutely dry, then I can post him for surgery. With surgery, yes, either I can go for a laryngoplasty or tympanoplasty depending upon his ossicular status. So if his ossicular status is normal or not, how can I find that? Yes, I will examine his ears properly under the microscope before I take him up for surgery. I will also get tell me any test. Yes, I will get an audiogram done. That will tell me if the hearing loss is around 40 decibel. Then it can be a ossicular erosion also. Maybe his ossicle is eroded. Which is the most common ossicle to be eroded? Yes, it can be a incus erosion, which is most commonly found. So if there is any ossicular abnormality, then I will go for tympanoplasty. I can also go for a patch test to see if when I patch, if the hearing becomes worst, it means that there is ossicular discontinuity also. So I operated him for his perforation, for his chronic mucosal otitis media. His ear was absolutely dry for 6 weeks following the antibiotic. And what I did for him was a type 3 tympanoplasty for a type C Austin defect. Are you getting me? Type 3 tympanoplasty. Type 3 tympanoplasty, what can it be? It can be anything, whether you put the temporalis fascia graft on the stapes head or on the foot plate, or you put a PORP or you put a TORP. All that can be type 3, right? So I did it for a type C Austin defect. The graft that I used for him was a temporalis fascia graft. So now you see that how a patient presents and how we approach. That was just a simple thing to just summarize the whole thing, how the patient will present and how you will approach and how you will summarize everything that you have learnt up till now in chronic mucosal otitis media. This was just a short glimpse of how you approach a patient in the OPD when the patient has come to you with a complaint of ear discharge, and when you have diagnosed him as a chronic mucosal otitis media, how you use whatever you have learnt in this chapter in managing the patient. Now, please do not confuse it with the proper case presentation that you have to do when you get a short or a long case of chronic mucosal otitis media. There you take the proper long history and rule out many things. You rule out all the complications of otitis media, and all those complications we have not yet done up till this module. We will be doing it in the subsequent modules. So this was just a glimpse of the summary of this chapter. Before we see the video of ear surgeries, a note of caution for all my students. Please don't expect that whatever you are seeing, you are going to see. The moment you see, it will be absolutely crystal clear to you, like how it became clear to you when we read about it. The surgeries of the ear are not simple to understand, not only for you, but even for the PGs. It is not until they have assisted so many surgeries and they have reached up till the second year after assisting so many surgeries that they can actually make out what is being done. So definitely, if you see it for the first time, don't expect that it is going to be absolutely now perfectly clear and you will understand in the first time that this is whatever you are seeing. But I have tried my best to give you a glimpse, just a glimpse of what the surgeries of the ear mean. You have already understood it very beautifully when we have done the theory part, when we have understood the concepts part. This is just to give you a glimpse of what exactly we are doing in the surgeries. How much you are understanding is sufficient. I have tried my best to give you a very magnified view so that the steps that you need to know, at least they are visible, and how much you are understanding after seeing this is perfectly okay. So now this is a patient who came with a complaint of left ear discharge for the past 5 years, and on examination there was a large subtotal perforation of the pars tensa, and he was taken up for myringoplasty. So now let us see how this surgery is done. Now here you are seeing that a post-oral incision is being given. This is what is known as the William-Wilds incision. That is, let me orient you. So that here, that is the upper end, that is the superior part. That is the lower part, that will be the mastoid tip part. So post-oral incision is given and the subcutaneous tissues will be deepened, the incision will be deepened up till the subcutaneous tissues, up till we reach the mastoid periosteum. This incision can be given with the help of a knife, or also a unipolar cautery can be used to decrease the chances of bleeding. So as you will see here, we are deepening and we have deepened up till the periosteum of the bone, and this post-auricular incision that we are giving is we are giving to retract the pinna forwards so that the pinna does not come on our way and does not hinder our access to approach the tympanic membrane to repair it. All these surgeries are done microscopically. This crest of bone, this projection of bone that you are seeing, that is the spine of Henle, and the mastoid antrum lies just behind that. But we are going anterior to it, that is the external aortic canal. We want to approach the tympanic membrane through the external aortic canal. So we have given an incision on the posterior wall of the external aortic canal at the bony cartilaginous junction of the external aortic canal, and we are now going to retract the pinna forwards so that we can go through the bony part of the external aortic canal to operate on the tympanic membrane. So now we can see a glimpse of the external aortic canal and also a glimpse of the tympanic membrane. So to retract this, yes, we are going to also cauterize all the blood vessels, all the bleeding blood vessels. We are now using a unipolar cautery. So we can have a glimpse of the tympanic membrane there. And yes, now we are putting a ribbon gauze. We will put a ribbon gauze through the external aortic canal, as we are seeing here. And we will pull it out so that the pinna can be retracted forwards. Yes, if you see it for the first time, it appears so scary, so it is for everybody. But this is how it is done. And don't worry, it will be replaced back. It will be stitched, sutured back, and it will appear absolutely normal. So now the mastoid retractor has been applied to keep the pinna out of our focus. And yes, through the external aortic canal bony part, now we are able to see the tympanic membrane, the subtotal perforation of the tympanic membrane. So what will be our next step will be to freshen the margins of the perforation. The margins we know have got epithelized, because of which the healing process has stopped. So we are going to remove this epithelized margins so that the margins become fresh again and they will now heal. So a thin margin from all around the perforation has been removed. Now we are raising the external auditory canal epithelium. We will raise it up till the tympanic membrane, and we will raise the tympanic membrane, the whole of the tympanic membrane, along with the external aortic canal epithelium, this that we are raising. And this flap is what is known as tympanomeatal flap. The name itself tells you tympano means tympanic membrane and meatal means external aortic canal, the meatus. So we are raising the tympanomeatal flap. So here we have been raising it from the bony part of the external aortic canal. This epithelium forms the outer layer of the tympanic membrane. So up till we reach the annulus, we will reach the annulus, and from there in this patient we are going to do an underlay. In underlay, what we do is we place the graft under the whole of the tympanic membrane. So now we are taking the graft, and yes, this is the most common graft that we take, the temporalis fascia. Can you see this white glistening thing? This is the temporalis fascia, which lies over the temporalis muscle in the temporalis, in the temporal fossa, and the incision was the same post-oral incision, and this graft has been taken. And can you see how thin it is? This is being passed through the external aortic canal, and the tympanomeatal flap which was raised is present here anteriorly. You can see it anteriorly here, and it has been raised above. The whole of the tympanic membrane has been raised above, and now this graft is being passed under the whole of the tympanic membrane which has been raised above, and this will now be properly positioned so that when we replace the tympanomeatal flap back, we will not be able to see the perforation. So now this tympanomeatal flap, this is the external aortic canal epithelium along with the whole of the tympanic membrane which we raised and we had put it forward. So now we cannot see any part of the perforation. It has been beautifully closed with the help of the graft. And if at all the patient had any ossicular discontinuity, so when we raised the tympanic membrane, the tympanomeatal flap, we would have reconstructed the ossicular chain also with any type of tympanoplasty, whichever was the ossicle missing. Accordingly, we would have done the tympanoplasty. We would have placed either a PORP or a TORP according to the need, and then we would have replaced this tympanomeatal flap. So this is the procedure how myelingoplasty is done, and I hope now if the steps are asked, you will be able to write very beautifully, or anything about myelingoplasty is asked, you will be able to tell it very nicely.